With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with MicroMicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and MicroMicelle technology.
OIE Broadcasting is the emerging leader in social media.
We use scientific entertainment to drive more patients into your office.
Visit oiebroadcasting.com and sign up today.
Hello and welcome to the Open Your Eyes podcast. I'm Dr. Kerry Gelb, the host of the documentary Open Your Eyes. If you're new here and you like our interviews, press like, subscribe, share, and hit the bell to get notifications of great new interviews. Also, please leave comments. Great news, you can now watch our full-length documentary, Open Your Eyes, on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. If you wear glasses or need a spectacle correction, you may have considered refractive eye surgery. Corneal refractive surgery, including LASIK and SMILE, remain the most commonly performed refractive surgeries, both with excellent visual and safety outcomes. Today's guest, Ohio-based optometrist, Dr. Jeff Augustine. Dr. Augustine has devoted his entire career to the optometric management of the refractive surgery patient. Dr. Augustine has written several iconic articles on refractive surgery. He's a refractive surgery educator and lecturer and is involved in many clinical projects. Dr. Augustine, thank you for joining me today.
I really appreciate the invite, and I'm looking forward to sharing this information to everybody that's out there that's either interested or would have had a procedure done in the past.
Well, I thank you for that. So let's start off with what are the most commonly performed refractive surgeries? And if you could just talk about it, but then we're going to go into detail on each one.
Okay. So, my day entails a potpourri or variety of different types of procedures. I work with all 3 types of laser procedures, PRK, LASIK, and SMILE. In addition to those 3 procedures, I work with the intraocular lenses for lens replacement. Also, I work with ICLs, and I also work with patients that require a procedure called cross-linking. So my days got a variety of different things. And as time has gone by, different approaches have occurred. Technology has advanced. It's sort of like the evolution from the early 90s to where we are in 2020 today.
So go ahead.
So there's not one in particular that supersedes another. I guess it depends on the patient's the patient's ocular, issues, what's best for them, what their avocation is, what their occupation is, the anatomy of the eye. So there's a variety of different decision making when it comes to picking and choosing the right procedure for that patient. The round peg has to go in the round hole.
As an optometrist and the optometrists out there, patients are asking us every day, they want refractive surgery. Who's a good candidate for refractive surgery? And then we'll get into the specifics of the different types of refractive surgeries. And so let's start off with who's a good candidate before we go into, and who's a poor candidate.
I think you have to look at a couple of different things. Corneal thickness is going to be one of the biggest factors for making it successful as far as the decision making concerning which particular procedure. Also, those patients that may be becoming contact lens intolerant. Also, those patients that may have jobs and different types of hobbies and things that they're looking for to become free of wearing glasses and contacts. So there's not one in particular. There's a whole variety of different decisions that go into making what would be a primary candidate for laser vision correction.
And who's a poor candidate?
A poor candidate would be those patients that have thin corneas that may not qualify for a laser procedure. Some patients' expectations may be extremely high. They may not be a good candidate for the procedure. Those patients that may have extreme dry eye may not be a good candidate for the procedure. Those patients that have different corneal diseases such as keratoconus are certainly not a good candidate for the procedure. So there's a host of different contraindications to having laser vision correction.
So let's talk about the tests that you do, the workup. What are the tests that are done pre-op for a refractive surgery patient?
Okay, there's a variety of diagnostic tools that we use in order to make sure that the patient is a good candidate. We do what is called topography. We also do pachymetry. Topography is looking at the surface of the eye and looking at various curvatures to make sure that the astigmatism is assessed properly. We also look at pachymetry. Now, pachymetry is corneal thickness, and you have to be absolutely sure that the patient's got ample corneal thickness in order to make sure that it's safe. Also looking at the lens itself inside the eye to make sure that there's no cataract formation. Retinal assessment is critically important as well. And also meticulous understanding of the refractive error of the patient, both in a dry state and as well as a cycloplegic state, to look at the accommodation of the patient. So those are all, those all go into the testing. There are some other tests that we do in regards to assessing dry eye before the patient undergoes the procedure. So the patient actually is there for about two hours when it comes to a workup on a laser vision correction patient. Now, we also do ultrasounds, things of that nature for those patients that might be undergoing maybe a lens-based procedure, such as an ICL, or would be lens replacement surgery.
Now, you mentioned corneal thickness and pachymetry. What is the best way to do that for a refractive surgery candidate?
Well, the diagnostic system that I'm working with is called a Penacam. And so the Penacam is able to assess anterior curvature, posterior curvature, the corneal curve, as well as the corneal thickness. So that's my go-to for looking at corneal thickness issues.
And what kind of thickness are we looking at to make them a surgical candidate? Obviously it'd probably be different if it's PRK, LASIK, or SMILE. So if you could just walk us through the thickness and what kind of thickness that we're looking for.
Well, normal thickness of a cornea is around 550 microns. Okay. And when you're talking about SMILE, LASIK, and PRK, they're all basically the same formula. It's called the Muller formula. And what that's doing is it's looking at the diopters the patient has and what type of optical zone we're going to be working with when it comes to PRK, LASIK, or SMILE. The average amount of corneal thickness that is either ablated or removed per diopter is about 17 microns. So for instance, if we have a patient that comes in who's a -3 diopter sphere, and we're going to work with an optical zone of, let's say, 6.5, the amount of tissue removed for that particular patient's going to be around, well, you have to multiply 3 times 17. So that's going to be about, I believe, 51 microns. So you have to look at the microns that are being removed out of the cornea, look at the corneal structure, and make sure that the integrity of the cornea is maintained in regards to strength. So everything that we do is all mathematics, and we have to leave a certain amount of tissue in the base of the cornea to maintain the structure of the cornea.
Right. So when we're looking at the pachymetry, is there any pachymetry that the optometrist could do in his office if they don't have a sophisticated instrument a very expensive instrument like a pentacam, can they just use a DGH or to get an idea how thick the cornea is, or an
Yeah,
OTT?
you have to, I think it all goes together with, you have to have topography in order to look at the curvature of the cornea, in addition to looking at the pachymetry or the thickness. You can do a handheld pachymeter, but that may not give you, that may give you a central reading, but you also want to have peripheral readings on the cornea to fully assess if there's any type of any thin cornea in the periphery. But, certainly a handheld instrument could help get things started for you.
Now, are you using a wave scan?
Yes.
So tell us what a wave scan does and why it's important.
Now, a wave scan can help me in a couple different ways. It can help me with assessing the refractive error on an objective measurement. So I use that primarily for that.
And so you're using it like an autorefractor?
That's right.
How about for aberrations?
Yeah, the wave scan can also give us aberrations as well. I haven't used, the one I used to work with quite a bit was the Vizx had a nice wave scan.
The
I
eye
know,
design? The eye
yeah,
design?
I don't know. I no longer work with that one. I work with the NIDEC. There's a NIDEC wave scan that I look at, as well as we also work with an Alcon one as well.
And how does that, what else does it give that may be different than the typical autorefractor that somebody may get in an optometrist's office that also gives aberrations?
Yeah, it assesses coma, spherical aberration, and trefoil. It can give me an idea if the patient does have a lot of aberrations prior to the procedure, but it also can give me an assessment post-operatively as to what may be bothering a patient in regards to, nighttime halos and glare and that type of thing.
And if you could explain some of these aberrations that you just mentioned, trefoil, coma, what is that? What is it? Why do some people have it? Why do other people not have it? And why is it important to fix it when you're doing refractive surgery?
I think you want to get the best quality of vision for the patient. So by looking at those higher order aberrations and working with a certain type of a laser that could assess that and better treat that, then that will increase the quality of the patient's vision for nighttime. The thing that I find is that the more dramatic curvature changes and amount of laser vision correction that occurs on the patient, the higher the probability of having those type of aberrations.
And do you use AccuTarget to look at scatter?
Yes, I do. I like AccuTarget quite a bit. I use that also for looking at the dry eye patient as well, because that assesses that as well. I used to use that quite a bit with when I was working with the camera inlays for presbyopia.
So a lot of people, a lot of optometrists, the public, we don't use AccuTarget for these optical scatter index. So can you give us a little bit more detail about what it does and how it helps you and to help the patient?
Well, I use the ocular scatter to kind of look at and assess the quality. It gives me a good idea of the quality of the tear layer, as far as, and it also gives me an idea if there's any lenticular aberrations associated with the lens, because it can tell me a little bit about cataract formation. So that's why I use the scatter index on the AccuTarget.
And if you notice there's a lot of scatter, how does that affect your decision as far as whether to go forward to do refractive surgery?
Well, maybe an indication to maybe get the tear quality. It can get I need to get the tear quality better for the patient, get and get a better assessment of the lens inside the eye. And it may be if I get a higher scatter index, then we may be leaning towards a lens-based procedure than more of a laser-based procedure.
How often are you fooled when you're doing that on the younger patient, that you don't realize, you don't think there's a cataract there, but that comes up positive?
I think then I would lean towards more assessing the quality of the tears and the surface of the cornea. If it was a younger patient, I looked in and the lens was clear.
And what kind of workup is being done for dry eye prior to refractive surgery, and how will that affect the outcome of the surgeries?
Well, with the advent of working with the SMILE patient, I've had a dramatic decrease in the amount of dry eye patients postoperatively with the laser vision correction patients. Just because of the mechanics of SMILE versus the mechanics of PRK, and also with LASIK, because no flap is created with SMILE. It's all just done internally. So the corneal nerves are maintained in the integrity, which helps with the dry eye postoperatively on the SMILE patients. I generally don't have to use any type of pharmaceutical such as Xiidra or would-be Restasis in those SMILE patients. It's very rare compared to that of LASIK and PRK.
Now, if somebody's already on one of those dry eye medications such as Xiidra or Restasis, how does that affect your decision making going forward? So if somebody's at home and they're interested in refractive surgery, but they have dry eyes and they're already on Xiidra or they're already on Restasis, how does that affect your decision making?
Well, in the clinic that I work, we have a dry eye specialist. And so if they come in with the predisposition of dry eye with being on those particular medications, I'll refer them over to, his name is Tom Chester, and he handles and gets those patients prepped and ready for surgery. They may require punctal plugs. They may require some other modalities to help treat that dry eye.
And how about you mentioned OZ before, the optical zone. Why is that important, the size of the optical zone, when you're doing this type of procedure?
Well, the optical zone is really important because if we have a smaller optical zone, then less tissue is going to be removed out of the cornea. The larger optical zone will remove more tissue out of the cornea. So we're able to go between a 6.0 and a 6.5 optical zone when working with our SMILE patients. So instead of removing, let's say, 17 microns out of the cornea with a 6.5 zone, then we can maybe use a 6.0 zone and go down to 15 microns, which preserves tissue.
And if you preserve tissue, then you have a better outcome.
Well, by preserving the tissue maintains the structural integrity of the cornea, because we want to maintain the strength of the cornea, so we can change the optical zones based on the pachymetry and also maintaining a base. We like to stay with the SMILE patients. We like a residual base of about 275 microns.
And you mentioned, or it's mentioned that that we want a white to white less than 11.4 millimeters. What does that mean?
Well, that used to be more important, but it's less important now. We found that I work with patients with a white to white of 11, and so it hasn't been a big factor. I think I think that's at the beginning when we were working with the procedure, we were more attentive to the white to white, but at this point in time with the surgeons with their surgical skill, it hasn't been that critical.
And white to white, you mean the horizontal diameter?
Yes.
Okay. So now
see, that becomes important with the SMILE patients because the Visumax docks to the cornea. With the LASIK procedure, it's not quite as, if we're using a different type of laser system, it may dock to the conjunctiva. So the white to white isn't as big of a factor.
Great. And since the pandemic, the number of refractive procedures seems to have increased. It looks like the statistics show that it has increased. I think some of the reasons their glasses were foggy, they're spending a lot of time at home looking at a computer. They maybe have more time. Have you found that to be the case?
Yes, I have seen that. I've seen an increase in the procedure. A lot of it has to do with wearing the mask and the fogging of the glasses. People tend to not be going on trips and vacations, so expendable income is going into this elective procedure. I think in all, elective procedures have increased. Also from a cosmetic standpoint uh, let's say lid procedures, cosmetic procedures have increased, and also the refractive surgery side has increased as well.
And how about the increase in myopia over the years with the increased digital devices, kids not going outside as much? How is that going to affect refractive surgery going forward, considering by about 2050, they expect half the world population to be myopic?
Well, when it comes to the efficiency of the procedure, the laser procedure, actually, I prefer to work with myopic patients versus hyperopic patients. They tend to have a better outcome working with myopia. But I think that you're exactly right in regards to what's happening in the world. Our environment's changing, and our near point tasks have dramatically increased. So certainly we're going to see an increase in myopia as well.
And the incidence of high myopia over -5 is about 10% globally. And as you mentioned before at the beginning, there is an option for people that are very, very nearsighted with implants with implants that actually have a prescription that we call phakic implants.
Right. I work with the Star EVO ICL, and so if those particular patients can be extremely happy patients to work with. I've worked with the ICLs since 2005, and what's recently changed within the last couple of years is we're able to correct for astigmatism now with the ICL, and also the peripheral iridotomy is no longer needed because of what they call the EVO ICL. It's got a small port in the central area of it, which allows the aqueous flow to go back and forth, so no PI is created. As far as the ICLs go, we're able to do bilateral ICLs same day, and within a day, those patients are extremely functional and happy.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
So let's talk about LASIK. Let's dive into LASIK. Laser-assisted in situ keratomileusis is what LASIK stands for. I think even the doctors forget what it actually stands for after a while, just by using the acronym over and over again. Let's start off with the type of lasers that are used. There are two types of lasers used in LASIK. Let's talk first about the type of laser that's used to make the flap. What is that laser, and how is it different than the one that's used to actually change the prescription?
Well, the laser that is utilized to create a flap is called a femtosecond laser. And it's what that does is it makes small little cavitation bubbles in the corneal wall, and that causes a separation of the cornea. You can also set it at various levels as far as the flap thickness. It's extremely predictable compared to what I had back 20 years ago with a microkeratome. So the microkeratome was the early instrument utilized to create a flap. And I've been working with the femtosecond lasers. We have a Visumax and we have an IFS, two different types of femtos, and both have different nuances associated with them with docking. But the femtosecond lasers have been a fantastic addition to creating the flap for LASIK from a predictability standpoint and the ease of the patient, because the pressure it doesn't go up as dramatically as it did with the keratomes.
And how high will the pressure typically go up now?
I can't remember off the top of my head the exact amount of pressure increase, but I know with the Visumax laser, the patient's fixation is maintained throughout the whole lasering process, but I can't give you specific numbers on the pressure.
And so now we make the flap. And now we have to do the treatment, and we use an excimer laser. If you could talk about the different types of excimer lasers, the wavefront ones that utilize wavefront, non-wavefront, and pros and cons.
I guess you have to get a pretty good assessment of the patient preoperatively to pick the type of excimer laser that you want to utilize for them. So there's wavefront and wavefront guided lasers. The technology in that market is continued to evolve, and the outcomes with those particular lasers have been fantastic.
So tell me about some of the different brands that are used.
Well, in our center, we've been using a Nidec laser, which is a topography guided laser, and we also use an Alcon laser, which also is a topography guided laser as well.
So, and how do you decide which one you're going to use and on which patient?
Well, generally, the go-to laser for simple myopia is going to be our Nidec laser. If it's a more sophisticated prescription, let's say mixed astigmatism or hyperopia, we tend to go with the Alcon laser.
And explain what wavefront guided laser does and how that helps, and by getting rid of the aberrations.
Well, what happens is with those particular lasers, it individualizes the patient's cornea, assesses the aberrations, and does a specific personal treatment to that particular cornea.
And that specific treatment, when we're getting rid of the aberrations, does that help with night vision afterward? Does that give a little bit more crisp type of vision compared to the non aberrometer based wavefront lasers?
Yes, in my experience, the patients have better increased quality of vision at nighttime, as well as quality of vision during daylight hours as well.
So, and how long does patients always want to know, how long does the procedure take?
The average procedure, if we're doing a LASIK procedure, takes about 8 minutes from start to finish. That's a bilateral procedure. And our SMILE procedure takes about 7 minutes. It's a little bit quicker than the laser procedure, because it's only based on one laser, not two.
And what's the advantage of LASIK over SMILE? Or disadvantage? What's the advantage of SMILE over LASIK?
There's probably, if we look at some of the data, the one advantage is that there's less dry eye affiliated with the SMILE patient. Postoperatively, patients can resume quicker in normal activities because there's no possibility of flap trauma. So patients don't have to wear eye shields the day after or immediately following the SMILE procedure. You can get back to exercise within a day with the SMILE procedure, and patients can wear eye makeup within a day or so, or within a day after the SMILE procedure as well. Research is pointing that there's less chances of what they call corneal ectasia with the SMILE procedure, because there's no flap created on these patients, so the wall isn't being weakened.
Explain what corneal ectasia is and why we're so worried about that.
Corneal ectasia is a complication associated with laser vision correction, that the corneal wall becomes weak, kind of like a tire that's got a weak spot in it. If you have a tire with a weak spot in it, it kind of bulges in the opposite direction. And so that's what's happening with these patients that have corneal ectasia, is that there may have been an issue with an aggressive amount of tissue removed, or would be they have a predisposition for keratoconus that wasn't showing up when they initially had the procedure, that may have been there, that wasn't diagnosed. So corneal ectasia is a weakening of the corneal wall, which results in optical distortion of the cornea. But
And
we're able to treat a lot of these patients as far as, let's say the patient does have corneal ectasia. We do a procedure called cross-linking on them, which makes the corneal wall rigid and prevents further ectasia. And then they may be able to undergo additional laser procedures such as PRK to recorrect their vision.
And how often do you get ectasia, unexpectedly as a side effect?
I can't specifically give you the statistics of it as far as maybe 1 out of 10,000. It's a very rare procedure, or it's a very rare condition, especially today when we have such really excellent diagnostic platforms to avoid that type of complication after a laser correction. Years ago, we didn't have the diagnostic equipment that was as predictable today that could look into warning signs for developing corneal ectasia.
So walk us through a LASIK patient, how the procedure is done, and then we'll go into the post-op. So we talked about the pre-op.
LASIK is going to be a 2-step laser procedure. The first step is going to be with the femtosecond laser. That's going to create the flap. The second portion will be with the excimer laser. The flap will be elevated, and the ablation will take place on the corneal bed, and then the flap will be repositioned. So a two-step laser process.
And what kind of medication would they need post-op, and how long would they need it for?
Well, actually, preoperatively, I start with having the patient do lid scrubs for 3 days to have a sterile environment around the lids and lashes. And post-operatively, I have the patient on a topical antibiotic 4 times a day for a week, and I also have them on a topical prednisone 4 times a day for the week. Sometimes I extend the prednisone based on the refractive error and the amount of treatment that they may undergo. I'll keep them on it for additional week twice a day. Also incorporate artificial tears throughout the whole process. Incorporate artificial tears, preservative-free, throughout the post-operative period.
And what are some of the side effects that people could have from LASIK?
Probably the number one side effect initially may be halos and glare, and that's secondarily due to corneal edema, but in most cases that resolves after the healing has occurred. Generally, they have that for about a month. You have to be also careful of what they call striae or folds in the flap, and you have to be cautious of that initially. That's why we have the patient wear the eye shields. Be careful touching or around the eye. A bump, a rub may cause a wrinkle in the flap, and that can be easily adjusted surgically. Another complication that you have to be careful with is dry eye, and that can be assessed preoperatively. And with a more aggressive approach postoperatively, patients will generally not have the dry eye chronically long term. Another one that we have to keep an eye out for is what they call epithelial ingrowth, and what that is the cells on the top surface called the epithelium can migrate underneath the flap itself and proliferate in the interface. So you have to keep a close tab on that. So those are going to be probably your top 5 issues to face. And a lot of those are not long-term complications, but just short-term complications, such as the halo glare associated with the edema, the dry eye, epithelial ingrowth, microstriae. Those things tend not to be debilitating complications. Also, you have to keep an eye out for what they call DLK. And what DLK is an inflammatory response in the interface of the flap. And that usually you have to keep an eye out initially for that. That's going to be a relatively rare complication, but it can occur.
So if you see ingrowth, how does that treated?
Ingrowth is treated by lifting the flap and removing those cells.
So you always have to lift the flap if there's ingrowth?
So in some cases, we can utilize a YAG laser to eliminate the ingrowth as well.
And how about if there's DLK? How do we handle that?
A couple different ways I handle DLK. DLK can be handled, one, by lifting the flap and washing the interface, or two, it can be handled by aggressive corticosteroid use. It depends on to me, it depends on the presentation, whether it be a very diffuse or is it just around the periphery. If it's diffuse throughout the flap, I have the surgeons lift and wash.
Is there any reason why somebody would get these two type of complications, or it just happens?
There's, I think in regards to the DLK, there may be some type of inflammatory response that initiates these white cells to proliferate in the interface. So you have to kind of look at that. As far as epithelial ingrowth goes, we have to be conscious of the integrity of the epithelium during the surgery. You have to be cautious that the patient doesn't have soft epithelium or any type of basement membrane dystrophy that could cause those cells to be entrapped in the interface.
And what about sands of Sahara? That was big at the beginning.
That's the same thing as DLK, same type of appearance. That was pretty common, or it wasn't common, but when the microkeratomes were being utilized, that's when you saw more of sands of Sierra than DLK compared to the femtosecond lasers that are utilized today.
So it's a pretty similar process to DLK. DLK is kind of the new sands.
They're synonymous, same name.
Okay. And people are worried that if they're having a LASIK procedure and they sneeze, what happens then?
I'm trying to think if that has occurred. I think if you feel this sensation that you're going to sneeze, you can indicate that to the surgeon so he could take the appropriate measures to stop the procedure at that point. You got to, and we don't want any spray going up into the laser head to affect the optics from a sneeze.
So I always felt like the laser that tracks like over, like thousands of eye movements. So if you move or whatever, the laser could automatically shut off and kind of moves with you.
That would be, I think with the sneeze, that would be a gross movement rather than a micro movement.
Fair enough. So how about people who have like autoimmune conditions such as rheumatoid arthritis? Can they have the procedure?
I have worked with patients with rheumatoid arthritis. I guess it depends on the corneal integrity. As far as those patients tend to be more predisposed to dry eye. The healing responses. I just recently worked with a SMILE patient that had rheumatoid arthritis, and the healing response was, there was no dramatic healing response and normal outcomes. And I continue to work with those particular patients.
Now with LASIK, with the flap, if you have somebody who's a very competitive athlete, maybe even a professional athlete, is the flap something we have to worry about? And would we steer them more towards SMILE or even the older fashioned PRK?
Yeah, I tend to look, when I interview the patient, look at what their hobbies, likes are, those types of things. If they're they work with martial arts, they're boxers, they're in a job that may have risk for ocular issues, then I tend to lean towards those patients undergoing PRK or would be SMILE if they qualify for that based on their refractive error.
And how about age? Every once in a while, you get a patient who's 55, 60 that wants to have LASIK. What's your feeling about that?
I think the biggest thing with those particular patients is to do a really good assessment on their lens to make sure that that they don't have cataracts. Even if they do have early cataracts, it may be a good idea to contemplate a lens replacement surgery than would be to do a laser procedure. Also, I think, we have to, when you're dealing with that age group, you're dealing with monovision patients, depending on their job and occupation. And as you know, the accommodation system changes from age 40 up into, 60, 70. The accommodation changes based on the a dysfunctional lens. And so I tend to be more, if you hit that age group of 55 to 60, I tend to be more of a lens-based procedure rather than would be a laser procedure.
So typically, say they have really no significant cataracts, they don't have any cataracts, so lens changes. Would you talk them out of it and tell them, let's wait until you have a cataract? At this point, you're 55 years old.
No, I discuss clear lens replacement or refractive lens exchange on them, whether they have a cataract or not. They may want to have a multifocal interocular lens put in, and the technology of those is fantastic now, and so they're able to see both distance and near with minimal amount of aberrations.
And how common is a clear lens replacement? And is there an issue doing it?
No, I think it's in our practice, we have the availability to do lens replacement surgery. A lot of centers out there may not have the availability to do lens replacement. And so for me, it's a relatively common procedure, especially in when we're talking about high myopia in that age group, or would be any type of hyperopia, because I find that, if you do a lens exchange, it's a material that goes inside the eye. There's no biological healing associated with it when it comes to doing a laser-based procedure. It's more of a permanent solution than a temporary solution, because if you end up doing a laser procedure and the lens continues to change, then you're chasing your tail. And so I tend to like lens-based procedures.
And what do you have a cutoff for corneal procedures like LASIK, SMILE, PRK for age? Is there a cutoff that you guys use?
Yeah, on a cutoff on age, I don't. I work with some patients that may have had previous cataract surgery that are not happy with their outcome from having cataract surgery, and they may be 70, 75 years old, and we do LASIK on top of them to refine their post-operative cataract results. So age, isn't really a big factor. I work with patients that are 18 years old, that may be going to the military for some and don't want to wear the glasses and contacts for that, all the way up into the 70s.
So if they haven't had cataract surgery, and do you have an age cutoff for refractive surgery procedures, corneal refractive surgery procedures? Like if so,
I start really being attentive to
say
age.
That again. I'm sorry, I stepped.
I become very attentive to age when the patient hits about 55 years and older.
OIE Broadcasting is the emerging leader in social media.
We use scientific entertainment to drive more patients into your office.
Visit oiebroadcasting.com and sign up today.
Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
Each generation was supposed to be healthier than the last one. Lifespan was supposed to be increasing. We were supposed to be in this paradise by now. Instead of getting healthier and healthier, it seems to have gone the opposite way.
Millennials were projected to be the first generation in history to not outlive the generation before them.
We are certainly headed for disaster.
I think a lot of people are beginning to question the whole story.
We live in a time where the paradigms are shifting. And the optometrist, in my opinion, is one of the best kept secrets.
The public doesn't realize about going to the eye doctor. So many different diseases actually manifest in the eye. The back of the eye is the only place in the body that you could actually see the blood vessels.
Completely non-invasively, you could screen thousands of people, not just for their eye health, but for their whole body health.
Because this disease is here, it's also going to be here.
And I can look into the back of my eyeball, and there are expert doctors on the ground who are looking at my eyeball while I'm doing it.
The eye is the canary of the mind.
The eye is the kingdom.
Will everyone please open their eyes?
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.